Well, good afternoon, everyone, and welcome to today's IPHAM webinar. I'm Ron Ackerman. I direct the Institute for Public Health and Medicine. Before I introduce today's speaker, I'd like to remind you all that we encourage any member of the listening audience to submit questions at any time throughout the presentation. To do so, simply click the Q&A button at the bottom of your Zoom screen. At the end of the presentation, we will move through each of the questions with time permitting. Today, I have the pleasure of introducing Dr. Lindsay Allen, who will present to us on her work examining the impact of Medicaid expansion on emergency department wait times and throughput, which are key indicators of emergency department crowding. Dr. Allen is Assistant Professor of Emergency Medicine at the Feinberg School of Medicine here at Northwestern University. She's a health economist and health services researcher and member of the Buehler Center for Health Policy and Economics. Her research centers broadly on policies designed to improve health and outcomes and healthcare access for disparity populations, especially through state-level policies and programs such as Medicaid. Dr. Allen, we're very excited to have you with us here today, and I'll turn the microphone to you now.
Thank you so much, Dr. Ackerman. I appreciate the welcome, and thank you so much to Adela and Ryan for their efforts in bringing the seminar to life. I know they work so hard to put this together, so we appreciate it. Thanks for having me. I am, as Dr. Ackerman mentioned, going to be talking to you about Medicaid expansion and emergency department wait times. And so this is joint work with the fabulous Kosali Simon from Indiana University and one of her terrific PhD students, Kong Jian, who I believe is going to be on the market within the next year or so. Okay, so I think as a way to do some level setting, the first thing we have to talk about is why does the emergency department matter? Okay, and so the emergency department has taken on new roles since its inception. Okay, and so for everyone who kind of knows that meme that you show kind of how something started and then how it's going, I think we can do something similar with the ED. And so how the ED started was as a place where people could receive care for true medical emergencies, okay, things that are life or limb threatening. Now, how it's going is a little bit different. And so we see that the ED has really taken on this expanded role in the healthcare system. And one of the biggest things that we're seeing is that the ED is operating as a source of safety net care for people that might not have anywhere else to go. And so this often comprises the Medicaid enrolled population or the underinsured. And we're also seeing that people are attending the ED when they need after hours care. So a lot of times primary care physicians will only work until about 5 o'clock. And if you need to get care for yourself or your child after your primary care doctor is closed up shop, sometimes the ED is the only place where you can actually get seen. Now, urgent care centers and retail clinics and kind of more and more so these days, telehealth have done a really good job of kind of offering some alternative care sites for unscheduled care during those after-hour times. But as we're going to see later in the presentation, when you are a Medicaid enrollee, those options aren't always available to you. Okay, the ED also performs a lot of adjunct care. Okay, so there are a lot of situations where you might get care at another provider, but then they tell you to go to the emergency room either because they think you need kind of different resources that they don't have available. They want to be sure that they're making the right diagnosis. So the ED has taken on a lot of that role as well. Okay, and so what we're looking at is kind of an increasing number of ED visits. So a couple years ago, we were up to 143 million annually. And at the same time, we're losing resources in the ED. And what I mean by that is we're seeing very frequent closures in hospitals and with their EDs. Okay, so we have visits going up, supply going down. And for all these reasons, the Institute of Medicine has declared the emergency department kind of system as at its breaking point. Okay, so that's why we really care about kind of what's going on in the emergency room. All right. And so one of the things that we've seen as a byproduct of the ED taking on this expanded role and doing all of these, playing kind of all of these different roles in the healthcare system is very long wait times. And so I'm sure all of us have visited an emergency room and waited a very long time to see a provider, to get treated once you've seen the provider, to get discharged once you've been treated, or to be admitted once you have actually seen a doctor and they decide that that's where you need to head. Okay, and so what you're looking at right now is a map showing the median length of stay in EDs kind of across the country before individuals are admitted to a hospital. And so the darker red states are displaying a median of 350 minutes wait time. Okay, even at the very low end of the scale, so those lighter colored states in the Dakotas and Montana, you're still going to wait a median of 100 minutes before you get admitted to a hospital. Okay, so clearly something's got to give here. Long ER waits are very problematic for a host of reasons. And I think we can see some of those reasons come to life in the following reviews that we've received as part of Northwestern Memorial Hospital. Okay, I did not know that this resource existed until I started preparing for this talk, but there is something kind of like a Yelp for hospitals. And I have the citation listed. If you guys are able to access the slides after the talk, you could read through some of these. They're pretty interesting. So first we have DeMonte, who said a 3-hour wait period in the ED is not accurate. I came on a Sunday night and I left without being seen after waiting 4 hours. So DeMonte got fed up and he just left without ever seeing a doctor. And you might think, okay, maybe DeMonte didn't need to be in the emergency department. If he was not sick enough to have to stay and get care, maybe he should have gone elsewhere to begin with. Okay, and I want to challenge that perception, okay, by offering you the story of Patricia. So Patricia said she loves her doctors at Northwestern, but she hates the ER. She was having a heart attack and she hadn't even had her vitals measured, okay, 2 hours after she went to the ED. Okay, her heart rate dropped to 20. I'm not a medical doctor, but that sounds like a bad thing. And so she had to make the decision to get into a cab and go to another hospital. This woman was literally having a heart attack and had to leave the emergency department to go elsewhere so that she could get seen and have a stent put in the next day. Okay, and we're not just talking about people with heart attacks. These are oftentimes people who are in very serious pain. So we have Aquanetta, who at the time this review was written, it was 6:18 p.m. They had been in the ER since noon. And they also had the comment that the waiting room was very cold. And so that sounds uncomfortable in several ways. Okay, and then we have the experience of Nicole. And I think at some point we've all been Nicole, we've all vibed with Nicole. Nicole says in all caps that this was an awful experience. It felt like she was in county jail and the wait time was over 6 hours, never go here. Okay, so these are just a sampling of kind of the stories of people from the ED, but these are very common trends that we see. So we have this kind of phenomenon of extremely long wait times, and it contributes to all sorts of, kind of undesirable things like pain and suffering. The longer that you are sitting in the ED and not being treated, of course, you're going to start feeling worse. That's longer that you have to sit there in pain. Okay, we also see changes in clinical outcomes. And so there's tons of studies showing that patients don't do as well when they have to wait longer. And that just kind of makes intuitive sense. Okay, one thing that people don't consider as frequently is our readiness for a disaster if it would happen. Okay, so when the EDs are all tied up and very crowded, that means we have less capacity for disaster preparation. And so that can be anything from, a school bus full of children that were in a crash to what we're seeing with COVID over the last couple of years. We need the ED to be available when these big problems hit. And then of course, we saw previously that at least 2-3 of the individuals left without being seen. Okay, and this is important. I want to kind of to focus on this for just 1 second. The idea that patients are leaving without being seen is not necessarily a good thing. So on the one hand, like with DeMonte, we might be thinking that maybe if patients are leaving without being seen, maybe that's a kind of right sizing of ED demand. So maybe it's a way to kind of sort out the individuals that didn't need to be there in the first place. But a small, like 10%, but important kind of proportion of these individuals who are leaving without being seen end up right back in the emergency department, usually with something more serious, or they have to go straight to being admitted as an inpatient. Okay, so it's really undesirable for patients to leave without getting the care that they might really need. Okay, and then of course we do see that it feels like jail. Okay, so long wait times lead to feeling like you're in jail. And as a reminder, she did say county and not state. All right, so we want to avoid that at all costs. All right, so why are emergency department wait times so long? Why do we see this crowding? And here I'm using the idea of long wait times and crowding kind of interchangeably, but there is a really expansive and complicated literature on how those two things relate. Okay, we can turn to Asplin's model of ED crowding. And he and his co-authors say that, okay, we have these 3 kind of buckets of things that happen that kind of determine what an ED wait time or crowding level is going to look like. And the first bucket is input. And so when I say input, I'm talking about who is showing up to the emergency room that day. Okay, so this comprises conditions, events, or system characteristics that contribute to the demand for ED services. So who's coming through that front door? All right, and for those of you that are familiar with Anderson's behavioral model of health services use, that's a useful framework within this framework to kind of think about all of the different factors that could prompt somebody to seek care, first of all, and then secondly, choose the ED as the setting in which they seek care. Okay, so when we think input, think kind of patient volume or kind of the type of patient that's headed to the ED that day. Next, we have throughput, and this is everything that happens once you're actually in the emergency department. Okay, so these are the ED care processes. Okay, so everything from triage to room placement to your initial evaluation to your testing to your treatment, all of these things can fluctuate in terms of how long they take, and in turn, how long wait times back in the emergency room waiting room are lasting. Okay, and then finally, we have output. And output has to do with how are patients leaving the emergency department, okay? So we can call this patient disposition. And I just have 2 examples up here on the screen. The first is you can be discharged, okay, to an inpatient bed, and this depends on the availability of inpatient beds. So right now we're hearing in the news about how there aren't any beds left in our hospitals, okay? And so what you'll see when you go to an actual ED is patients lined up in their emergency department hospital beds in the hallways, okay, waiting for sometimes hours and hours until an inpatient bed opens up that they can be transferred to. Okay, that's what we call boarding. Okay, and that is this very popular topic in the crowding literature. Okay, a lot of attention gets paid to boarding and kind of the role of the inpatient side of things in backing up the flow of ED care. Okay, so somewhat less attention gets paid to what happens if you are discharged as an outpatient. Maybe you're getting discharged for outpatient follow-up, okay, outside of the hospital walls. And in that case, they have things like social workers or people like social workers in the emergency department who help you connect with those resources. But those conversations and setting up those follow-ups take a lot of time that then can trickle back and disrupt the flow earlier on in the emergency department process. Okay, so all that to say, Medicaid expansion could have really influenced a lot of those factors. And so I want to do some level setting with what Medicaid is. I'm sure everyone's heard of it, but I do find sometimes that people aren't as clear on what Medicaid does. They get it mixed up sometimes with Medicare. And so as a reminder, Medicaid is the kind of federal and state program that provides public health insurance to low-income adults, okay, pregnant women, and then some children. You might also hear kind of CHIP, the Children's Health Insurance Program, kind of in the same breath as Medicaid, and that's because a lot of children are covered by CHIP if they have a higher income level, then they would qualify for Medicaid. And so Medicaid is a means-tested program, which means that you cannot make more than a certain amount of money each year as either an individual or a family and still qualify. And so right now we've got about 72 million enrollees in the program, and that includes 28 million children. So way back when the Affordable Care Act was kind of first being debated, Medicaid expansion was a really, really controversial topic. Okay. And so the basic premise of expansion is that we're going to say, all right, we're going to raise that income threshold to 138% of the federal poverty limit. Okay. So we're allowing people who make a little bit more money to enroll in Medicaid. And this was huge. This was really huge because it allowed a lot of single adults, a lot of childless or child-free adults to enroll in public health insurance, which has very far-reaching consequences, positive consequences, which I'm going to talk about kind of at the end of the presentation today. Okay, but a lot of the states were not feeling this. They were saying, hey, you can't really force us to expand. And so states were given the option of expanding Medicaid or not. All right, that's Medicaid in 1 minute. Right, and so what that looks like is most of the country, so all of the blue states that you're seeing on this map adopted the expansion. And then we see frequently along party lines, okay, the orange states here not adopting at this time. And this is current, okay, as of a few days ago. Right, so we're going to leverage the fact that not all states expanded Medicaid to figure out what the effect of that expansion was on our outcomes. Okay, so let's think about all the ways that Medicaid expansion could have affected all of those crowding aspects, okay, that we talked about earlier. So recall, we have input factors, we have throughput factors, and we have output factors. In terms of input, there's a host of ways that Medicaid expansion could have changed kind of who's seeking care in the ED, okay? But one way it could have possibly influenced ED crowding and wait times is by increasing them, because we have all these newly insured people who were previously uninsured, okay, who now might be willing to seek care in the ED that they previously wouldn't have been willing to because they couldn't afford it. So in that sense, we might have seen demand for ED care go up. At the same time, we might have had this kind of opposing factor happen, which is a possible decrease in people seeking care in the emergency department because they've finally gotten connected to primary care. One of the main purposes of the Medicaid expansion was to help connect individuals to primary care. And the common thinking is that if you are connected to primary care, then you're going to be well managed for, perhaps your diabetes, and we're not going to see you in the ED as frequently for exacerbations of those conditions, right? In terms of throughput, we might see clinicians changing their processes of care in the ED as a result of the Medicaid expansion. So one theory, and then there actually is a study that has looked at this, says that physicians change the way that they treat patients once they become insured. Okay, and so they now know that this patient's covered by Medicaid, and so the hospital, the clinician's going to get reimbursed for certain procedures, and so one study has found that intensity of care increases in the ED as a result of Medicaid expansion. And then finally, we have output factors, and these could definitely be influenced by Medicaid expansion. So recall that these output factors a lot of times depend on what's happening in the inpatient side of things in the hospital. And just as volume could have changed in the ED as a result of Medicaid expansion, so also the inpatient hospitalization trends could change. And so it's possible that now we are seeing more people engage in perhaps elective surgeries. And so they're more likely to be admitted as an inpatient for that surgery in the hospital, which could back up wait times in the ED. Similarly, we might see this kind of depressing effect where people now have better access to primary care, which in turn helps them kind of reduces their need for hospitalization because their kind of ambulatory sensitive care conditions are being so well managed. Okay. So far, everyone who's been looking at each of these things, and there's some excellently done studies that I encourage you to check out, but everyone's been looking at volume. Okay, everyone's been looking at the number of patients kind of changing that enter the ED, that leave the ED, that end up being admitted as an inpatient. We're going to do something different in this study. What we're going to do is look at wait times. How does Medicaid expansion affect how long you're spending in the emergency department? Okay, and for that, we're going to use the CMS Hospital Compare database. This is a free data set. You can go online and download it today if you want to. Okay, and the whole point of this database was to collect information about hospitals to kind of improve transparency. And so into future patients, so patients as consumers of hospitals and where they get care can go online and check out kind of how different hospitals stack up against each other in terms of things like morbidity and mortality and wait times. Okay, so that's the data that we're going to use. Our sample includes all U.S. acute care hospitals with EDs in states that either never expanded Medicaid or fully expanded Medicaid in January of 2014. And I want to make this very clear because we excluded a handful of states that expanded Medicaid at different times. And that's because they wouldn't be really fully treated by the policy at the time period that we're interested in looking at. Okay, so we do exclude a handful of states. And then the data are available from CMS in rolling quarters. Okay, so we're looking at the time period from 2012 to 2017. This gives us kind of a good balance of pre and post period data points. Okay, once we kind of cleaned up this sample and we were left with our final analytic sample that was made up of just over 2,000 hospitals, and they were almost evenly split in terms of expansion state hospitals versus non-expansion state hospitals. I have kind of their characteristics here for you in table 1. We see that there are some kind of expected differences, but overall it looks pretty similar. We see some differences in ownership status. So for example, hospitals in expansion states were much more likely to be voluntary, okay, rather than public or private. And then we see the timeliness of care national comparison, which is relevant for our study, is both the states or the hospitals in expansion states and those in non-expansion states both had similar to the national average timeliness of care measures. Okay, so to start with, before the expansion occurred, they weren't really different in terms of how long it was taking patients to get care across a host of measures, not just in the ED. Okay, so how are we going to get at this? Okay, we're going to do something called a state level difference in differences approach. And while I could talk about this as approach for hours and hours, I'll just kind of summarize it by saying what we're doing is looking at the change in ED wait times, okay, our outcomes in treatment states before and after the policy was implemented, okay, before and after January 2014. And we're also going to use states that did not expand Medicaid as our control group, and we're going to similarly look at how their outcomes changed pre and post. Okay, the idea is that there are probably some kind of national trends that affected both of those groups, and by comparing our treated group's outcomes to the control group's outcomes, we can probably be more confident that we're accounting for those national trends, and the results that we see are due to the policy itself. Okay, for those of you that like models, this is what our model looks like. So I'll break this out for you piece by piece. On the left, we have our wait time outcome. And so that's going to depend on, it's going to be hospital H in state S, which may or may not be an expansion state at time T. And again, T here is at the quarter. And then we have our a binary indicator for whether or not the data point that we're looking at occurred after the expansion. So this post variable takes on a value of 1 if the data point happened after January 2014. Next, we have expansion, which depends on the state. This is equal to 1 if the state expanded Medicaid or not. And then we have a vector of hospital fixed effects. And this vector kind of controls for the things that the characteristics of hospitals that make them what they are and might kind of remain unchanging over time. Okay, so the fact that we're Northwestern Memorial Hospital, we're an academic medical center, there might be something about being the academic medical center that is Northwestern, okay, that we can't really capture in a model. And so we're going to use this fixed effect as a way of accounting for that. Okay, and then next we have our period fixed effects, and this accounts for kind of time trends, okay, that would affect everybody in our sample. Okay, so if we were looking at 2020, we would certainly need to account for the sheer 2020-ness of 2020, and that's what this would do. We're only looking at 2012 to 2017 though. And then the epsilon on the right is our idiosyncratic error term. Okay, so what we're most interested in is the coefficient alpha sub 1 here on the interaction term between that post variable and that expansion variable. And we argue that because we've met certain assumptions, okay, that this, the coefficient represented by that alpha is the causal impact of Medicaid expansion on ED wait times. Okay, so what outcomes are we looking at? We looked at those that were available in the hospital compare data set. So we have 3 outcomes that focus on time, and these are in minutes. The first one is how long a patient waited to see a provider upon arrival at the ED. The second one is from the time they arrived to when they departed the ED for discharge patients. Okay, so this doesn't include patients that were admitted or patients that left with being seen. This is the whole time that patients who were ultimately discharged from the ED spent in the emergency room. Okay, and then finally, we have the amount of time that individuals spent in the ED after the decision was made to admit them. So picture this as like those patients laying on hospital beds in the hallway. Okay, and now our next outcome is in terms of percentage. Okay, we're no longer thinking in terms of minutes, but instead we're looking at the percentage of patients who leave without being seen. Okay, so these are those patients who signed in. Okay, so they entered the ED, they went to the front desk, but then typically they just get fed up with waiting and they head out before ever seeing a provider. Okay, and so the way that the data are collected in hospital compare is that the hospitals have to take kind of samples of how long these various times are for patients each quarter, and then that gets audited by CMS, which helps us kind of helps improve the credibility of these. Okay, so in terms of results, okay, I'm going to take there's a lot on this slide right here, so I'm going to take you through it step by step. The first thing is that we're looking at that first outcome. So the number of minutes that patients spent in the waiting room before they ever saw a provider. Okay, and so we have some rounding going on here, but we started with a baseline of about 31 minutes. Okay, so before the policy happened, patients were waiting on average 30 minutes before they ever got to see a doctor. That's pretty good, in my opinion. I've waited much longer than that to see a provider. Okay, and then we find an increase, a statistically significant increase of almost 4 minutes. Okay, and with the rounding, this ends up being about a 10% change from baseline. Okay, so we see that the amount of time you spend in the waiting room waiting to see a doctor goes up by 10% as a result of Medicaid expansion. Okay, the second outcome that we're looking at, and I'm going to show you guys these graphically in just a second, but these are the average findings. Okay, so the next thing we're looking at is the number of minutes that patients waited before being sent home. So they went, they got seen, they got treated, and now they're being discharged. Okay, the baseline mean was 142 minutes. Okay, so people were waiting 142 minutes, and we saw an increase of 7.5 minutes. Okay, is this something that is it's statistically significant. Is it meaningful? Well, it's an increase of 5%. Okay, if you're sitting in an emergency department, with lots of pain and suffering, or you have a critical condition where kind of minutes matter, this matters. This is a significant amount of time. Okay. Next, we have the number of minutes that patients are being boarded. And so here we find a smaller relative effect. We find an increase, but it's only an increase of about 3.4%. And I'm going to show you something that I find really interesting about that particular finding in just one sec. Right? And then finally, now we're looking at the percentage of patients who just leave the ED without ever being seen. The number one reason is because the wait time was too long. Okay, so the baseline mean here is about 2%. So 2% of all ED visits are people leaving. Does that seem really high at first? Maybe not, but recall, we're talking about 143 million ED visits. Okay, so 2% of those leave because the wait time is too long. We find a 15.3% increase in that outcome as a result of Medicaid expansion. Okay, so what do these look like graphically? So what I'm showing you now is something called an event study. And so we look at kind of before that red dashed line, which is when the policy was implemented, kind of what did the coefficients look like before that period and then after that period. And the cool thing here is that we're able to see kind of how the impact changes over time. So for the first outcome we're looking at, so how long did patients wait to see a provider upon arrival at the ED? Okay, so before the policy occurred, we see, you can tell by these 95% confidence intervals that, things were pretty similar between our control hospitals and our treatment hospitals. However, once Medicaid expansion happens, we start seeing this very clear and sustained increase in the number of minutes that people are waiting to see a provider. Okay. Moving on to the next result. Now, this is the time that patients spend in the ED until they're discharged. We see something very similar. We don't really see much of a difference at first until the policy is implemented, and then bam, we see right away that increase, and we see that it's sustained over time. Now, why I'm kind of spending time on this sustained aspect is because when we look at boarding time, okay, we do see this initial increase, okay, but then it starts to resolve. It kind of disappears over time. Okay, these remember, these are data points occurring at the quarter. So while we do see this initial and kind of mean increase in boarding time, it doesn't seem like it hangs around, which we find super fascinating because boarding has always been kind of the number one reason that people think wait times are so long. Okay, and now in terms of the percent of patients, this graph looks a little bit different. That's because these data are only collected annually. Okay, so we don't have quarterly data just due to a data limitation, but we do see this kind of this increase that appears to be sustained, even though we do start seeing larger confidence intervals as time goes on, right? So we see that patients who are leaving without being seen is increasing. Okay, and so the punchline here, is that expanding Medicaid increased the time that patients waited to see an ED clinician by 10%. But if you think that I am going to run the risk of somebody screenshotting this and saying that, Lindsay Allen says that Medicaid expansion is the worst thing ever, you are so wrong. I am going to cover this with an infographic from the Center on Budget and Policy Priorities that talks about all the amazing things that Medicaid expansion has done. So we do find that there is this increase in wait times, okay? And that's not great, that's not ideal. And we certainly should look into this further. And I'm gonna offer some suggestions of how we might do that in just a sec. But I do feel just kind of obligated to point out that the Medicaid expansion has improved access to care, it's improved health outcomes, it's had even broader effects, which in terms of financial security. So I don't know if everyone realizes that kind of the main reason that individuals go into bankruptcy is because of their medical bills. And so we've seen declines in medical debt. We've seen declines in evictions. Okay, so this Medicaid expansion has very far-reaching impacts that we need to consider kind of in a balanced perspective when thinking about results from studies like ours and others. Okay, and then from a hospital perspective, because I'm sure I have a lot of NM people here, we also see that Medicaid expansion seriously reduced uncompensated care. And so uncompensated care is that that care that you deliver to people who can't afford care and you kind of just write it off, all right? Like you don't get money for that. Well, the big thing about converting the uninsured to insured is that now hospitals can recoup some of that money. Okay. All right, so what does this all mean? Okay, I'm not going to tell you I know exactly what's going on here because I have tons more studies I want to do here, but here are some of our initial thoughts. This could mean, and I say perhaps, all right, that ED input or demand for ED care increased. Okay, some studies appear to show that ED volume increased, some studies show it didn't, but we find some suggestive evidence that it increased without kind of these concomitant improvements in throughput, or what we can think of as supply side factors. So maybe hospitals weren't prepared for either the higher volume of patients or the higher acuity of patients that might have come into the ED as a result of expansion. And so when I say higher acuity, I'm talking about this phenomenon called adverse selection. And adverse selection is kind of this idea in economics that those who are most likely to need insurance are the most likely to get insurance. If you can predict that you're going to need healthcare in the coming year, you're more likely to sign up for insurance that's going to help you pay for that healthcare. It makes perfect sense. Okay, but what that means is that we might have sicker patients being the ones that are kind of selecting in to Medicaid enrollment. Okay, which might translate to the higher acuity patients in the ED, which might just take longer to treat. Okay. Could also be an issue of care intensity. Again, there is at least one study that's been done showing that physicians or other providers kind of change some of their clinical practice when they know that patients are covered by Medicaid versus being uninsured. And then I say this with, perhaps the question mark, because I can't caveat this enough. It could be that boarding isn't the problem in this case. And I almost feel sacrilegious saying it because boarding is like the thing in the crowding and wait time literature. But we do see that these kind of wait time increases among those who are boarded, we see an initial bump, but it kind of dissipates over time. So maybe that's not as big of a contributor as it typically is, at least in terms of our study. Okay, some considerations and extensions. So just things we should be thinking about. Okay, the first thing is that the field of research looking at changes in provider behavior and processes of care is wide open. If anyone is interested in looking at this, there is absolutely a market for figuring out how providers changed their processes of care in response to the insurance change, okay? And so I know that we have some amazing data available here at Northwestern through the EDW. I mean, if anyone's willing to dig in, I'm happy to help out, to provide suggestions. I think this could be a really interesting study that is sorely needed. Okay? The next thing that I want people to really take away from this is that access to care doesn't just mean having insurance. Okay, and what I mean by that is, a few slides ago, I showed how it's possible that we would have seen a decrease in emergency department care because people now have Medicaid insurance and they're now able to see primary care providers when they previously wouldn't have been able to. Okay. That's not always the case. Just simply enrolling in insurance does not take care of all of the systemic and larger challenges and barriers that there are to connecting patients to care. Okay, one of the big ones is that Medicaid is treated very different by providers. Okay, and so those of you in Illinois probably know that Medicaid is sort of notorious here for not paying its bills on time and for being kind of really administratively burdensome on clinics and on practices. And so what that means, and they've studied this in really interesting secret shopper studies, is that if you call and say, hey, I'm privately insured, can I get an appointment? They'll say, sure, we're taking new patients. But if you call and say, hey, I have Medicaid, are you taking new patients? They'll say, no, sorry, we're all full up. Okay, and so there's lots of work that's being done on those secret shopper studies that if you're interested, be sure to check them out. They're so interesting. Okay. The second thing is that access is not just financial access to care. Access to care, being able to actually get to a provider's office, depends on things like, do you have childcare available to watch your kids, okay, while you're going? Do you work a 9-to-5 job and that, you work the same hours that your primary care doctor works and you can't get off work because you're paid by the hour? And that would be a huge hardship, having to miss out on those few hours of work that it would take for you to go and get treated. Okay. And then I think we also need to think about how telehealth fits into all of this. So over the course of the past 2 years, we've seen this explosion in telehealth because of COVID. People don't want to have everyone all up next to each other in these offices and practices and clinics and emergency rooms. And so we've really turned as a larger health system to telehealth. And there might be some opportunities for telehealth to kind of mitigate some of that burden on the ED and connect people with care. So that's a field that's really blossoming right now if you're interested in doing any work in that space. Okay. And then finally, I want to talk about opportunities for patient education. Okay. And so I imagine that a lot of you guys have seen those infographics where it's like, should you go to the ED? Should you go to the urgent care center? And it will say things like, chest pain, or I don't know, profuse bleeding or something, heart attack, I don't know. And then on the urgent care side, they'll say, okay, if you have something like a small laceration, if you have something like a sprain or a small break, urgent care centers are more appropriate for you. They're just more clinically appropriate. They're less expensive. That's where you should go. Well, part of the reasoning for those infographics is that we're trying to educate patients about when the ED is the right setting for whatever their condition is. And I think the problem with that is that we're really putting the burden of kind of acting as a diagnostician on the patient who didn't go to med school. It's not the patient's job to know when they're supposed to seek care in a more resource intensive versus a less resource intensive environment, right? And so I think if we want to think of this in terms of education for patients, kind of helping them better understand when they should be going to the ED versus not, we might want to focus more on designing a system of care that makes it very obvious to patients where they should be going for what type of care. All right. I think we've attempted to do this. I believe Northwestern has like a fast track section of the ED, so patients don't have to make the decision. They can just walk in and then we can say, hey, you go to this more fast track side of things versus you go over here, you have a true emergency and should be seen in this more resource intensive environment. But so far, things like that don't seem to be working as well as they could be, as evidenced by these extremely long wait times that we're seeing. Okay, so with that, I am nearing the end of my time. I'm going to turn it over for some Q&A. I welcome all questions, comments, and feedback. And if you're interested, please feel free to take a look at the study. It was published recently in Health Services Research. And as always, get in touch with me. I'm happy to hear from you. Thank you guys so much.
Thank you, Lindsay. That was wonderful. There are several questions in the Q&A that I'll try to go through and help facilitate. I wanted to start off organizing kind of a general theme, which, you started by describing this, the vision for emergency departments as really being the sort of access point for people with major medical issues, trauma, things that likely would result in hospitalization and needed immediate treatment. And, it's really become an enormous tent for everything. A lot of the lower acuity visits might be driven by lack of access through other channels. And so, the hospitals and the ER administrators, right, are kind of being forced to figure out how to put under that tent some really high technology, really advanced specialist care for all of those major trauma things that you don't know what's going to walk through the door next. And they end up being there at the ready, and what shows up are runny noses and, everything from children to older adults, medical to surgical, trauma to mild illness. And so if you were asked to design a system, like not knowing what was already in place for the challenge of how you create access and provide care for all of those issues, I doubt anybody would say, well, let's have them all walk into one tent and we'll figure it out when they get there. There's no way to sustain it financially, and it's interesting too. Like it results in bad care, and you described a lot of those sort of bad quality indicators. So I'm curious how Medicaid specifically or broader policy actions can improve the system overall. And there are some things that probably happened with the ACA expansion, like access also to immediate care or urgent care or primary care medical homes for patients that might have altered access sort of in that sort of the first step of your diagram, the sort of inflow of patients. And I wonder, did your analysis control for some of those things, like the kind of secular trend in things like freestanding emergency departments or expanding urgent care or other parts of the system which might have affected who shows up in the ED, and how does Medicaid specifically think about that when they design these policies? Because they're not only creating, coverage, as you said, to sort of solve the ED problem, but it's all of those other things as well. And I don't know if we know whether it's doing better or worse in some of those other areas, but I'm specifically interested in how it affected the results of your study.
Yeah, of course. Thanks so much for the question. So yeah, we did control for those trends, and the way we did it was with some brute force. So we included these kind of hospital fixed effects, okay, which would account for kind of the market of urgent care centers that might exist around any given hospital. And then we also accounted for the secular trends that might have affected kind of all of the hospitals in the analysis. And, the trend in urgent care, the urgent care explosion kind of really happened during this 2012 to 2017 timeframe. So it's, to your point, we certainly, if we hadn't controlled for that, we might have some biased results here, because a lot of, I have to make a plug for another study that I've published in HSR with Janet Cummings and Jason Hockenberry. We show that urgent care centers actually do reduce non-emergent ED visits for the Medicaid population. And so that absolutely could play into here. So we did control for that with exactly that thought in mind. As to the second question, which is Medicaid policies and kind of what's going on in terms of things that they've tried, I can tell you one of the things they've tried that hasn't really worked out is increasing copays for patients who visit the ED for things that are either more emergent or less emergent. The idea being that if patients have some skin in the game, so if they know that they're going to have to pay a higher copay, and when it comes to Medicaid, we're talking on the order of like $1 to $5 as a copay, right? Maybe that will change their behavior. Maybe that will disincentivize their visit. Okay, but what we see is that it didn't really make a huge difference. Okay, another thing that not just Medicaid has tried in one state, and remember, because Medicaid is a state-run organization, the policies differ. Okay, you've seen one state's compilation of Medicaid policies, you've seen exactly one state's compilation of Medicaid policies. But something that some private insurers have tried, and Medicaid and one or two states have tried, is denying payment for non-emergent ED visits. And as you can imagine, this has been extremely controversial. And so I believe the first to do it was Anthem. And they said that, we're going to, if you go to the emergency department for a condition that a prudent layperson, okay, would recognize as being not emergent, we're going to not pay for that. But you're not going to know we're not going to pay for it until you get the bill in the mail. Okay, they sent one letter out to patients, letting them know that this change was going to happen. And I consider myself to be a prudent lay person. I study this stuff as part of my job. But if my kid's sick, okay, if one of my little toddlers is sick, and I think there's a chance that it might be something more serious, I'm going to take them to the emergency room, because I know that's where they can get the best care, and whatever resource they would need, it would be there. okay? And so this idea of kind of balancing a policy on the idea that a patient is supposed to know what's right and not right is one that's being talked about a lot. Okay, it's getting a lot of press. So I don't know if I answered your question, but I at least spoke to it.
Oh, that's great. Thank you. I'll go through a couple other questions that are here. Recognizing that you even said your study, happened before 2020. What do we know about what coronavirus has done to ED, both wait times and disparities in the ED?
So many thoughts about this one. It's such a good question. I think we all need to be thinking about it and also looking into it because we don't have as many answers as we should have at this point. Okay. And so a couple of things. So first of all, the EDs are, so because I now am in an emergency medicine department and I have access to these fabulous clinicians who are on the front lines of treating patients in the ED, I get to hear some of these kind of anecdotal stories. And it seems like it's been kind of a wave through the past 2 years. Like in the beginning, you had people kind of terrified to go to the emergency department. And so like actually the emergency department was not bad. Wait times weren't as long as they were. But then as a kind of reaction to that, you have this kind of latent pent up demand from people who were purposely not going to the ED when we didn't know much about COVID-19, that then once we said, okay, we can wear masks, we can kind of be out and about a little bit, we saw the ED get jammed right back up again, actually more so than it had been prior to COVID. Okay, so it's been, in terms of wait times and ED demand, it's fluctuated during the pandemic. I think another thing to consider is how access to alternative care sites, okay, has changed during the pandemic as well. So again, I got to go back to urgent care centers just because when we're talking about this acute unscheduled care, they are the market for that. And urgent care centers have now gone, several of the Northwestern ones have gone appointment only. Okay, so the whole marketing premise, the whole thing about urgent care centers is that you don't need an appointment. You can just walk in and they stay open late. Okay, they're kind of filling that access gap for a lot of people. But now Northwestern has changed several of its urgent care centers to appointment only. And so where are those people going to go? Okay, maybe back to the ED. So that's another thing that could kind of influence the patterns that we're seeing in the ED.
Megan McHugh asks, she points out and wonders your thoughts about that new Medicaid enrollees after expansion are unlikely to distribute themselves evenly across emergency departments. Rather, they may be overwhelming safety net hospitals in low-income neighborhoods. Have you considered looking at sort of the subgroup of those hospitals specifically?
We actually did. Hi, Megan. I'm so glad you're here. We actually did look at that. We kind of broke this up a bunch of different ways, and we looked at hospitals that existed in areas that were described as safety net. And so the definition that we were using and what CMS uses is if you have more than a quarter of your patients are Medicaid or uninsured. And so we actually looked at different potential impacts divided along those lines, and we didn't really see a whole lot shaking out that way. Another thing that we did look at is by volume. So we were positing that maybe hospitals that are bigger to start with might be more easily able to adapt to this kind of influx of newly insured, but nothing really shook out that way either. I actually do want to go back and revisit that. So thank you for bringing it to my attention. I'm going to go back and dig up those old analyses and see if we can breathe some new life into them.
When you started the presentation, you talked, as an example of waiting 6 hours before being seen, but the mean time was like 42 minutes, I think, in your study example, prior to the expansion. And I wonder, DeYoung Kang asks, have you looked at median time? So the question there is like, are outliers driving the means in some way, and do medians react differently perhaps in the pre and post period of ACA expansion?
Yeah, absolutely. And we actually did look at median. So we looked at mean outcomes but the outcome of interest was median wait times. And so exactly because you could have those really long outliers kind of skewing the data a bit, the outcomes that we were looking at were median wait times in minutes.
Wonderful. There's one more question from Joe Feinglass, and Joe, highlights some work that they did looking at a spike in ED visits in Illinois from 2014 to 2015, around that time of that expansion, and points to the also secular trend of increasing urgent care, but specifically that people are going to urgent care and then being referred to the emergency departments, and the effect that the way urgent care is designed may not accommodate for all patients, and they end up needing to be seen really twice, once in the urgent care and then over at the emergency department. Did you consider that in your analysis, or is that something you also observed?
So I love this question, because I'm specifically looking at this right now in terms of telehealth. So do we see kind of patients who are initially treated in a telehealth setting end up needing more care kind of down the line? And so I see a parallel there, Joe. And also, hi to you. It's great to have you here. So several thoughts. The first thing is that while we do find in our paper, a different paper, that urgent care centers do kind of take on some of those non-emergent ED visits among the Medicaid and underinsured population. There is a study that was done a while back. I think it was Atif Mehrotra, maybe Scott Ashwood, who looked at retail clinics, which are different from urgent care centers. Okay, they offer less resource intensive care than urgent care centers do, but they actually found that a solid proportion of the care being delivered in retail clinics was actually what they would classify as new use. So it wasn't substituting away from a more expensive care setting. Instead, it was actually people who, if the retail clinic hadn't been there, they wouldn't have gone to see any sort of doctor, ED or not. Okay, and so I think there is certainly the secular, so urgent care centers are taking on some patients. They might be spurring new use similar to retail clinics. We don't know, no one's done the study yet. But then at the same time, they're also referring patients to the ED. And this is something that I've had trouble kind of reconciling since I've been able to talk to a lot of the ED docs in my department, because looking at the data from the Urgent Care Association of America, they actually find in their kind of annual survey of members that referral rates are pretty low from the urgent care center to the ED. Like fewer than 3% of patients are referred to the ED from an urgent care center. But when I talk to my colleagues who are actually living this on a daily basis, they say they see a lot of patients coming in from the emergency department. And a lot of that has to do with the idea that if you're in an urgent care center, or if you're in a telehealth visit, or if you're on the phone with somebody, it's the doctor can't see you. The doctor can't look at you, and there's really no substitute for that. So some of this certainly could be related to it. Thanks for the question.
Well, we're at the top of the hour, Lindsay. I want to just say on behalf of the audience, we're really grateful that you came and presented your work today. We're delighted to have you here at Northwestern as a relatively new addition to our faculty. And I think you probably invited a lot of interest and potentially new collaborators to your doorstep. So hopefully you'll have some beneficial connections from this presentation today. It was really wonderful.
Thank you so much. Thank you for having me.